Hello. Today we're here to talk about challenging conditions in the post-acute setting, a lens on pressure injuries, VLUs, and DFUs, a very common topic that we need in wound care. Your faculty for today is Ms. Emily Greenstein, Ms. Daphne Hodges, and myself, Dr. Terry Treadwell. These are the disclosures that show who we are affiliated with. The program is provided by HMP Education and the HMP company. It's supported by an educational grant from 3M Healthcare. Our learning objectives for today would be to examine best practices for skin and wound management as we incorporate compression therapy as the gold standard for venous leg ulcer care. We want to review some strategies that include skin protection, managing bowel burden, optimizing wound environment, and offloading for diabetic foot ulcers. And we'll examine strategies to prevent and treat pressure ulcers using the best practices for assessment, education, prevention, and treatment protocols as outlined on this slide for you. I've been asked to speak first on the management of venous leg ulcers. As we talk about venous leg ulcers, we talk about the cause of them, and venous hypertension and venous leg ulcers are intimately associated. But it's very interesting that if you stop and look at it, about 35 to 60% of all people worldwide have venous hypertension in their lower extremities. The interesting thing about that is that only the 1 to 3% of the patients will ever develop a venous leg ulcer. So the percentage of people developing an ulcer is really very low compared to the number that actually have venous hypertension. It leads one to think that maybe there's more to it than just venous hypertension, but that's not the topic that we'll talk about today. We do have about 500,000 patients in the United States who have venous leg ulcers that are treated annually. About 80 to 90% of all leg ulcer cases that we see in the United States are due to venous leg ulcers. So it's a very common problem that we need to deal with. The difficulty in treating a venous leg ulcer is knowing exactly what to treat. As we implied, we have venous insufficiency in a goodly number of patients. We also know that if we are dealing with open wounds like a venous ulcer, we have biofilm and bacteria. Biofilm, as you know, is just a way that bacteria can present themselves on a chronic wound. We know that we have an inflammatory wound environment, which includes proteases and inflammatory cytokines. We also know that nearly all of these patients have edema and lymphedema of the lower extremity. All of those we'll talk about a little bit more as we go forward. We have underlying conditions which must be addressed. Obesity is a large one, especially in our part of the world down in the South. We have patients who are very large that have venous disease. The interesting thing about this is that venous disease in patients who have obesity is rarely related to venous valve disease. And about 66% of the patients do not have venous insufficiency due to venous abnormalities themselves. That's another whole topic that we could discuss at some other time. Diabetes is also an associated underlying condition. We know that there are a number of people who have diabetes. Most of the time we think about that associated with diabetic ulcers, but interestingly, about 30% of patients who have venous leg ulcers will also have associated diabetes, something that we should consider as we're considering treatment and management of these patients. We have a number of patients, about 20% or so, who have associated vascular insufficiency, which will influence the way we treat venous leg ulcers, and we'll address that as we go through. One of the big situations that we don't talk about much is patient compliance, and as you know, that is a major issue. We talk about proteases and the amount of these inflammatory cytokines that we see. Proteases are just enzymes that eat up tissue, as you well know. This is just a slide showing the prevalence of proteases in different types of wounds. As you can see on the far right, that in acute wounds, the protease levels are quite low. But in all chronic wounds, you can see that they range from pretty low to very high. All of these will help the wound not heal and cause problems with healing and the treatment that you're using. Well, how do we manage that, or what do we deal with? Well, the presence of bacteria being there will elevate your protease levels. Bacteria many times will make their own proteases and cause a problem. So we have to deal with the presence of bacteria, both in the planktonic form and also in the presence of biofilms. That is something that we have to deal with, and we'll look at that a little bit more. Damaged tissue will cause prolonged elevation of proteases, and that can be dead tissue, that can be dying tissue, just damaged tissue in the wound from the venous hypertension and other problems going on. Any type of foreign material that's in the wound can cause an elevation of the proteases and the prolonged elevation thereof. Prolonged exposure to inflammatory cytokines, and we'll talk more about how you get that prolonged exposure, but anything that's a continuing condition in the wound will cause elevation of the inflammatory cytokines. One that you might not have thought about is an elevated tissue iron level. We know that in patients with venous leg ulcers, they do have extravasation of blood into the soft tissues. The body can manage the protein part of the hemoglobin molecule and everything, but the piece of iron that's in every hemoglobin molecule is left and cannot be managed very well by the body. As a result, you have an inflammatory reaction due to that iron level until it can figure out a way to remove it from the tissue. But as you know, the elevated iron levels are what cause the discoloration of the lower extremity of patients who have venous disease. This is a photograph of an inflammatory venous ulcer. I'm sure many of you have seen these before. You can see it's draining. You can see the inflammation of the tissue surrounding the wound and how the wound does not look very healthy at this point. And our point is to try to make that better so it'll begin healing. This is another example. We talk about maceration of tissue that's caused by the drainage from wounds. It's not just the fluid. If it's just water, then most of the time you can spend a lot of time in the waters, especially in the summer. We can spend time in the swimming pool or in the lake or something like that. We may look like a prune when we get out of the water, but very rarely do we lose our skin. You can see in this particular picture, two small stasis ulcers that are there, but you can see the skin digestion or the maceration of the tissue as a result of the wound drainage. The drainage problem that is causing the loss of skin are the proteases that are in that wound fluid. So we must manage that in a way. How can we do that? One way would be to inactivate the enzymes. There are treatments that we can use to inactivate the enzymes. We can also decrease the production of enzymes. There are some other treatments that we can use. One way to do that is to use corticosteroids. Prednisone will help decrease the production of enzymes. Again, another topic for another day. We can use some dressings that will absorb and isolate the enzymes, keep it away from the skin so that it won't cause any problems. There's also a set of dressings that are out there that will actually bind the zinc cofactor. To have an active enzyme, it has to have the cofactor of a zinc molecule. And these particular dressings have a particle in there that will actually go in and bind the zinc and pull it out of the enzyme so that the enzyme is not functioning. So these are just ways to approach the treatment of this type of problem. So now that we've done all that we can to address the wound, get the wound hopefully in a healing phenotype, if you will, what do we do next? Well, the treatment of venous ulcers is compression, compression, compression. Compression therapy is the standard of care. A recent Cochrane review, they reaffirmed that, saying that compression therapy is essential for ulcer healing. So if you're really not going to do adequate or good compression, the chances of you getting the wound to heal is kind of low. The next statement is kind of interesting. It says, just like the legend of Cinderella in the real world, one size will not fit all. So what that means is that you don't just go to the closet or the cabinet and grab a compression bandage and pull it out and put it on. There are different types of compression bandaging that are available to us, and we'll look at that and see which one would be the best fit for your particular patient. Compression therapy is important for a number of reasons. One of which is that it improves venous insufficiency and venous hypertension, as you would anticipate. It also improves the lymphatic return. Why is that important to us? Well, you know, we were all taught that when you have circulation, that fluid leaks out of the capillaries at the arterial end, but the venous end reabsorbs most all of it, and what's left over is removed by the lymphatics. Recent work has shown that there is virtually no reabsorption of fluid on the venous end of the capillary. All of that fluid that leaks out at the arterial end has to be removed by the lymphatics. And so the lymphatic return and the lymphatic system is a critical part of treating people who have swollen extremities and helping wounds to heal. Compression therapy also helps improve the microcirculation of the ulcer bed. It also improves the capillary density in the wound bed, which we'll talk more about in a moment. We know that it reduces protease levels, and it also helps remove the edema and lymphedema fluid, which stimulates healing, and we'll look at those separately. The microcirculation, by removing the fluid from the tissues, it reduces the distance between capillaries as the swelling goes down. When that happens, we can facilitate transport of nutrients so the body and the tissues can heal and can have a better healing phenotype. Also, if you're having to use antimicrobials, the distance between capillaries means that you'll get a higher level of antimicrobial agents in the soft tissues between those vessels. We also know that compression therapy normalizes the veno-arterial reflux, which will help the complete circulation there. And it also helps the endothelial cells release anti-inflammatory mediators into the tissues, which will help reduce the protease levels, as we know. When we talk about capillary density, it's illustrated on this slide. We'd rather talk about it a lot, but as you can see, if you look at the far right-hand side of the slide, you can see in healthy tissue, this slide shows the density of capillaries shown by the triangle shaped line, and also the TCPO2, which is the amount of oxygen that's in the tissue. As you can see, we could spend a lot of time talking about it as you go across with different levels of venous insufficiency and problems with the leg. You get to the next to the last column there on the left, you see that the triangular line shows the capillary density, which is obviously very low, and the TCPO2, which is also low. We don't think much about that. What about capillary density? Is that a big deal? Well, if the TCPO2 caused by that capillary density is less than 20, I think most all of us would agree that the chances of that wound healing are very, very low. As we know, the TCPO2 usually needs to be above 40 if we're going to have a chance to get a wound to close. And so this may explain a lot why our wounds are not healing well if we don't have enough capillaries to bring enough oxygen into the tissues. How do we manage that? Well, if you look on the left-hand graph, you'll see that U1 is the level of capillary density at the beginning of this particular study. And then they use compression bandaging on that wound in the leg. U2 is the end of 1 week of therapy, and U3 is the end of 2 weeks of compression therapy. And you can see with the use of compression therapy, even after only 2 weeks of compression therapy, the density of capillaries has increased rather dramatically. And I'm told that the capillary density continued to increase with continuing compression bandaging. Well, what about the other side? If you look at the other graph on that page, they segmented these out a little bit more on wounds that heal quickly and ones who didn't heal so well. And you can see the dark diamond there. The ones that showed significant healing are the ones that showed the quickest return of capillary density. And so the better capillary density you have, you can see that the healing was better. The little stars there are in the other columns, and you can see that these showed delayed healing, but then again, you can see the capillary density did not return so much. So it looks like that we may have something else to look at. Obviously, measuring capillary density is fairly difficult in the clinical setting, but we may be looking at finding the fact that capillary density is a big deal in healing our wounds as we go forward and allowing the TCPO2 to be returned toward normal to allow for healing. Another thing that compression therapy does is will help get rid of the metalloprotease levels that we've seen. This is a study that was done, and you can see with the blue line, it says before treatment, the proteases are quite elevated. You can see by the line beside that, that after 1 week of compression therapy, the protease levels began to decrease, and with time, they continue to decrease even further. So compression therapy does add that help to us. The lymphedema and edema fluid that we can get rid of is important because edema and lymphedema fluid is not just water. That inactivates the normal anti-streptococcal properties of our skin, which is why people who have swollen extremities are more likely to develop cellulitis. The fluid in the leg actually inhibits mitogenic activity and DNA synthesis. And as you notice, there are higher levels of inflammatory cytokines, higher levels of proteases, and reduced levels of growth factors simply because the proteases are eating them up. So the compression therapy will help get rid of that for us. When we talk about compression therapy, there's some important information that you need to know. It's interesting to note that only about 50% of healthcare practitioners know that the ideal pressure under compression bandaging is about 30 to 40 millimeters of mercury. Also, we are told all the time that if you try to put a compression bandage on a patient who has an ankle brachial index of 0.8 or less, then you're going to have a problem and you should never use that. Only 30% of practitioners know that you can treat somebody with a swollen extremity if they have an ankle brachial index of less than 0.8. And only 12% know that the ankle brachial index of 0.5 to 0.8 or an ankle pressure of greater than 50 millimeters of mercury can be treated with short stretch compression without causing any major problem. When we look at the extremity, and this is just a cross section of a leg, you can see that we've got the bandage on it, we've got the skin and the tissues there, you see the muscles. And how does that affected by the compression? If we take an elastic or stretchy compression and put it on the leg, you can see where the green line is up there, green arrows. And we're making pressure on the skin, trying to squeeze the leg enough to get some pressure. Well, this pressure that we develop in the leg has to do with the law of Laplace. As you can see, the pressure that's generated is due to how tight you wrap it or the tension and the size of the leg. So the tighter you put it and the bigger the leg, the less the tension is going to be. So that's the thing that you look at. The interesting thing is that when we put in a stretchy compression bandage on, we're dealing mostly with making pressure on the skin, the subcutaneous tissue, and maybe some of the superficial vessels, because it's hard to put enough compression on that extremity to affect the muscles too much. One of the best ways to generate pressure throughout the leg is with a short stretch compression or a bandage that does not stretch much at all. And you can see in that illustration, the bandage that's put around the leg that doesn't stretch. When the patient walks and the muscles contract, then pressure is generated throughout the leg, not only in the skin subcutaneous tissue, but also in the muscles as well. That's called generating pressure from within, and it really is beneficial. We can look at that from this type of slide. You can see the pink line says that the resting pressure is about 30 to 40 millimeters of mercury. You can see it on the left-hand side of that graph. As the patient is lying around, it's about that tight. But when they begin to walk again, you see a little bump in the pressure, but not much because the bandage stretches with the leg as the leg expands. When the patient quits walking and the muscle relaxes, it goes back to the baseline. If you have a short stretch compression bandage, one that doesn't give, you put it on at a little lower tension, usually around 20 millimeters of mercury, 25 millimeters of mercury at the most. But when the patient walks and the muscles contract, you can see that there's a significant increase in pressure there, with the blue line going all the way up, sometimes to 50 to 60 millimeters of mercury. But as soon as the muscle contraction goes down, then you're back to the resting pressure of 20 to 25 millimeters of mercury. That's a good thing if you have a patient who's active, because you can generate higher levels of compression. The other thing too is when you're having a patient who has some vascular insufficiency, you're putting the compression on with lower resting pressure, so you're not squeezing the leg so tight to embarrass the circulation. If they walk, they get good compression therapy. If they get to having claudication or other issues with it, they stop walking, the pressure falls back to the lower level, and generally they have no further problem. The other issue is that with compression bandaging, we can actually improve the circulation. We talked about ankle brachial index of 0.5 to 0.8. This is a study that was done in patients who have that ankle brachial index, and you can see that they measured the amount of blood flow or laser Doppler flux under the bandages at different pressures. You can see the baseline flow on the left, and with 20 to 30 millimeters of mercury pressure, the blood flow under the bandage actually increased 33%. That's by getting the fluid out and having greater capillary density. You can see at 30 to 40 millimeters, it's still increased by 28%, 40 to 50, which I would never recommend in a leg that's has vascular insufficiency, is still improved under the bandage. If you look at this slide, the one on the left looks at the blood flow in the toes. At 20 to 30 millimeters of mercury, distal to the bandage, you still had an increase of 3% of the circulation. 31 to 40 and all did not do quite as well, but it really wasn't dramatic decrease until you got to 40 to 50. If you measure the toe pressure to again show the amount of circulation distal to your bandage, you can see at 20 to 30 and even 30 to 40, you increase the toe pressure significantly, so that you're actually helping increase the blood flow. You can also see the TCO-PO2 that's in the tissues there, depending on the pressure, and actually compression therapy increases that. So the bottom line is that there's no impairment of arterial flow up to a pressure of about 40 millimeters of mercury. So you really can help people improve their circulation by using compression bandaging. We've actually seen the ankle brachial index go up 1 to 2 numbers just by using compression bandaging. This is a patient who had a venous leg ulcer, just as an example. This patient had had the ulcer on her leg for 5 years with no improvement. She'd been treated with lots of antibiotics and multiple therapies, except nobody had ever done compression bandaging. As you can see, she does have some biofilm on the wound. We treated the biofilm, we treated the wound for the proteases, and we used compression bandaging. After 4 weeks, you can see she still had a little biofilm recurrence, but the wound is closing very nicely. After 8 weeks of therapy, there's no biofilm, wound is closing, and by 12 weeks of therapy, the patient is healed. And she has stayed healed now for over a year. So compression bandaging with attention to the details that we've talked about are very important. Well, you might say, well, we don't do that much compression at our wound center. Well, this is just 1 month of visits for us. This is just after the COVID situation. And you can see in 1 month, we saw 1,507 patients. We had 526 patients who came for compression bandaging or required compression bandaging, which was about 35% of our visits. And during that time, of those patients, 211 required just one leg to be wrapped, and 315 required both legs to be wrapped. And so you can see that that's a total of 841 compression bandages that we applied in our wound center in 1 month. So this is, again, about 35% of your visits, and that's about the number that everyone should be doing based on the percentages. So compression bandaging should be a very large part of every wound center. You should know how to do it. You should know when to do it. And you should know which one works best, whether it's long stretch or short stretch. And hopefully it will help you provide better care to your patients. Thank you very much. And now we'll pass the program on to Emily Greenstein for further information.
Thank you, Dr. Treadwell, for that presentation on VLUs. My name is Emily Greenstein, and I'm going to talk to you now about some strategies for skin protection and optimizing the wound environment in diabetic foot ulcers. So a couple of statistics to start with. 12 to 25% of patients with diabetes will develop a diabetic foot ulcer in their lifetime. It's the leading cause of diabetes-related hospitalizations and non-traumatic lower extremity amputation. Oftentimes, excessive pressure contributes to delayed healing in up to 94% of these ulcerations. Some of the challenges that we might face when dealing with a diabetic foot ulcer is the wide spectrum of the disease. Patients might present to your clinic from a callus to an actual open ulcer. They could have all the way up to a critical limb-threatening type disease. There's a variety of presentations. They could have just a foot deformity. They can have that callus or pre-ulcerative callus area, or they might have an ulceration. All of these things put them at an increased risk for infection. Another challenge that we often face with patients with diabetes and diabetic foot ulcers is that micro and macrovascular disease that they have. When we talk about neuropathy, peripheral neuropathy affects as many as 60% of all patients in their lifetime, and up to 80% of those patients present with foot ulcers. Autonomic neuropathy is the loss of sympathetic tone. There's increased arteriovenous shunting in the foot, which leads to defective nutrient flow. There's impaired autonomic regulation of sweat glands. This is what leads to that dry, cracking, or fissures oftentimes in their feet. There's increase in bone blood flow and subsequent osteopenia. This is often what leads to the Charcot foot osteopathy or that Charcot joint that they might develop. The chronic sensory motor polyneuropathies, that is usually involving the lower extremities and progresses centrally. This tends to be symmetrical. The sensory nerve fiber involvement leads to loss of protective sensation. So this is where our patients state that they don't have really any feeling in their feet. They can't feel much. There's motor nerve fiber loss that results in small muscle atrophy in the foot and flexion of the metatarsals. So this is where you get your clawing of the toes, those hammer toes, because of this. When we talk about the unique anatomy of the foot poses several implications for the presentation and treatment of infection. Recognizing that most infectious processes in the plantar aspect, and it's useful to understand the three plantar compartments of the foot, which are divided and the medial, central, and lateral compartments. Because of this, the intrinsic muscles of each digit are essentially confined within the respective plantar compartment. Untreated distal phalangeal infections may progress to plantar abscesses. So if you think about the foot, there's those three compartments. And if you have an ulcer on the end of the toe, that bacteria usually will spread into the compartment. The microbiology of the diabetic foot infection is dependent on the patient's environment. In the outpatient or hospitalized, and the severity of the infection itself. Is it mild, localized? Superficial ulcers usually are present in the outpatient setting and are caused by aerobic gram-positive cocci, such as Staphylococcus aureus or Staphylococcus streptococci. In contrast, our deep infections and more limb-threatening infections are usually polymicrobial in these patients. In addition to gram-positive cocci, the causative organism in this latter group may include gram-negative bacillus and anaerobes. Enterococci may also be isolated from the wound and is notable among hospitalized patients. So when we talk about vascular, micro and macular vascular problems in patients that have diabetes, there's two distinct types of vascular disease. The first is non-occlusive microcirculatory impairment. This is characteristically involving the capillaries and arterioles of the kidneys and peripheral nerves, and with significant effects in the diabetic foot. The second is macroangiopathy, which is characterized by atherosclerotic lesions of the coronary and peripheral arterial circulation. Both capillary blood flow and response to stimuli are reduced in the diabetic foot, suggesting that a functional microvascular impairment is a major contributing factor for diabetic foot problems. Diabetic patients commonly have occlusive disease involving the tibial arteries. That's when we do a ABI with ultrasound or an arterial duplex. Oftentimes in our diabetics, the ABI will show non-compressible, so your results will actually be higher. But when you do the arterial duplex, it shows that the waveforms that it's most commonly affecting the popliteal or that tibial area. In addition, the popliteal, superficial femoral, and more proximal arteries are less likely to be affected by atherosclerosis, which allows these vessels to serve as inflow sources for distal artery bypass grafts. So when we're looking at a patient who presents with a diabetic foot ulcer, our first step is to do an assessment. So we're going to take their history. Was it abrupt onset? Was it just showed up one day? Or has it been slowly getting worse over time? What is the patient's current medications? What's their current exercise habits? What's their use of specialized footwear? Then we're going to want to do a physical exam of the patient, making sure we're checking deep tendon refluxes, if there's any deformities, skin color, temperature, texture, presence of any ulcerations. And we're going to want to do our gait analysis and monofilament testing. For our vascular testing, like I said, we want to do an ABI, which is oftentimes elevated. So you're going to want to look more at the waveforms than the actual ABI number. In these patients, toe blood pressures or TBIs are a little bit more accurate because of those non-compressible vessels. We can also use transcutaneous oximetry to check the oxygen flow to the ulcered area. Arteriography and venous insufficiency ultrasounds are also helpful to rule out other conditions that can be contributing. For infection, we want to check for probe to bone test to any tissue cultures that might be needed, x-rays and MRIs as indicated. When we're looking at the wound, doing a wound assessment, we obviously want to do the size and depth. We want to look for any tunneling or tracks present. As you can see in these pictures here, the wounds did track or tunnel all the way through. Sometimes you will get those patients that have the connecting through and through ulcers. You want to look at the periwound skin if it's calloused or macerated. Any exposed structures within the wound bed, tendon, bone, muscle, joint capsule. Is there any type of tissue present? Is the tissue granulation? Is there hypergranulation? Is there slough or eschar? The amount and appearance of exudate. Is the exudate serous, sanguineous, or do you have purulence? Our next step is looking at managing these patients medically. So medical management includes their medications. What are they taking over the counter? Are they on any antidepressants, anticonvulsants? And then the big one, what's their blood sugar like? Is their blood sugar controlled? Are they taking their metformin? Are they taking their insulin, or are they not because they can't afford it? If there's an ulceration present, we want to look at offloading. Do they have the appropriate footwear? And then for neuropathy, but no ulceration, so they might just present with neuropathy or a pre-ulcerative calloused area. We want to make sure that they have appropriate football wear and are monitoring for any hot spots, making sure that they're doing that routine diabetic foot assessment on themselves at home. Next, we want to decide on the appropriate treatment. So unfortunately, there's a lack of consistency in management. This is often cited as a problematic factor in achieving healing in these patients. So treating, managing to the barriers to healing, utilizing the time acronym provides focused guidance for treatment decisions. So time is a acronym that Dr. Schultz and his group came up with about wound bed preparation. So it's tissue, infection, moisture, and edges or advancing edges. So looking for the presence of necrotic tissue, any concerns with infection or inflammation, and the adequate management of moisture. And then, like I said, the edge is non-advancing. When we look at considering what dressings we should use to treat these, we look at a couple of factors. We want to look at the wound measurements, the location of the wound, the presence of the surrounding skin. Is it friable or eroded? Is there viable or non-viable tissue in the wound bed? Is there infection or biofilm present? Is there any sensitivity or the patient's age? And then a big one is the patient caregiver's ability to change the dressing. We can have the best dressing in the world, but if the patient's not able to reach his own foot to change it, it's not going to do us any good. So we talk about periwound skin management. These wounds are the principal portal for entry of infection in patients with diabetes. Frequently, the ulcers are covered by a callus or fibrotic rim. The trimming of the hyperkeratotic tissue is important so that you can see the entire size of the wound. It is also kind of a gold standard in diabetic foot ulcers to trim that hyperkeratosis back to bleeding. We want to look for maceration. And then in these types of wounds, the exudate is usually a little bit more on the alkalinic range from about the 6.2 to 8.5. Noting normal skin pH is about around that 5.5 mark. And the reason this is important to note is because that certain bacteria thrive more in that alkalinic environment. Staph aureus especially thrives in a pH range of around 8. So making sure that we're selecting something that is going to neutralize that pH to the most close to the normal pH of skin is important. So options for peri-wound skin management or protection. There are zinc barriers out there. These are easy to use, but they're kind of messy. They can also cause a little bit of epidermal stripping when you try to remove them. There's a tetrapolymer-based alcohol-free barrier. A lot of you might be familiar with these. They come in sprays, they come in wipes, they come in wands. The problem with these ones are they can build up over time. And then our polymer cyanoacrylate barriers, these are the newest ones to the market. They can last up to 7 days. The nice thing about these is they will attach to wet, weepy skin. They provide an ultra-thin barrier. The problem is they're a little bit more expensive, but when you're only using them once every 7 days, they're also a little bit harder to obtain. So this is a case showing an example of the polymer cyanoacrylate barrier. So this patient was a 59-year-old male. He had diabetes, a diabetic foot ulcer. He had underwent surgical debridement of the area. He was treated with negative pressure wound therapy. It was causing a lot of maceration, so we discontinued that and started him on a total contact cast, which was changed weekly. And as you can see, the peri-wound skin did improve tremendously. Another option for peri-wound skin management is a specialty absorbent dressing. So these dressings are unique because they wick both horizontally and vertically. So you want to make sure when you're looking at a dressing that's a super absorbent is that it is holding that fluid in and sequestering it within the dressing itself. And they also come in a variety of types. They come in gels, pads, beads, granules. So they can also be helpful to prevent that peri-wound skin maceration. Now I'm going to talk to you a little bit about inflammation. So when we talk about inflammation in chronic wounds, the thought, or there's been a lot of evidence out there showing that chronic wounds get stuck in that chronic inflammatory state. When a wound is in a chronic inflammatory state, you have high levels of proteases and MMP activity. So we need to look at a way to bring those levels down so that the wound can go on to the remodeling phase. So one dressing that's available on the market right now is a collagen ORC or a collagen ORC with silver. What they are is it is a matrix is 45% oxidized regenerative cellulose and 55% collagen. These are more of a sacrificial type dressing. So what that means is your body naturally produces collagen in the rebuilding phase. So what you The problem, though, with chronic inflammation is those MMPs and proteases attack your body's natural collagen, so it's not able to lay down. So what we do is we put this synthetic collagen into the wound bed, which the MMPs and proteases attack the synthetic collagen, which allows the body's natural collagen to work like it should. The next thing I'm going to talk a little bit about is biofilm management. So one method that you can use, Dr. Schultz and his group came up with, it's a step down, step up approach. This just means you step down, it reduces the biofilm and bioburden. And then when you step up begins when the wound bed is prepped and ready for some advanced treatments. So this is an example of one silver dressing that's available on the market. So what is silver oxygenate salt technology? It's once a compound is exposed, then you get a redox reaction where one substrate is reduced and the other is oxidized. The silver becomes oxidized and released in 3 different ionic states, 1+, 2+, and 3+. The oxygen becomes reduced as a free oxygen molecule. This is important to remember as we talk about how the silver and the oxysalts work in this type of dressing. The reason it's important is because tissue wounding induces a rapid concentration gradient of hydrogen peroxide, H2O2. It's produced by the injured epithelium. So the body naturally produces some levels of hydrogen peroxide. The short-lived, highly cytotoxic nature of hydrogen peroxide is a key mechanism of the innate immune response in the control of infection. However, hydrogen peroxide levels must be tightly regulated as excessive levels damage structural protein in the extracellular matrix, adversely altering the regulation of signaling pathways and pro-inflammatory cytokines. It causes cell death and tissue necrosis. It has been suggested that regulating excessive levels such as hydrogen peroxide in chronic wounds may help reduce the hostile environment and stimulate healing. The harmful nature of the recruited inflammatory cells and their secreted products causes tissue damage, which propagates infection. This cycle leads to a destructive wound environment. Despite the high levels of inflammatory cells present in infected chronic wounds, their phagocytic and bactericidal functions are diminished. As a result, the wound becomes more susceptible to an increase in bacterial bioburden. So why do we care about all of this? We care about it because the basic take home is that the silver oxysalt dressing, when it's applied to the wound bed, gives an electron up, which creates the production of hydrogen peroxide in a low concentration, mimicking that's normally made from the body. So the low concentration promotes healing. However, if you're at a high concentration, like a bottle of hydrogen peroxide dumped on your wound, that causes cellular death and it is cytotoxic. So when we talk about looking at dressing selections, this is kind of just an easy guide if you want to look at, is it inflammation or do I have a biofilm present? If I have a biofilm or bioburden present, I want to look at using the oxysalt type dressings. If my wound is more on the inflammatory side, then I'm going to look at utilizing something that's going to bring down those MMPs and proteases. So I'm going to look at using A or C type collagen. So this is a case of an inflammation. He's a 7-year-old male. He had type 2 diabetes. His A1C was 9. He was currently on insulin. He presented with this wound on the top of his foot. He was treated with a variety of topical products. You can see at day 10, it was still about the same. Then it ended up getting worse, actually. So what happened was he wasn't really taking his insulin. He wasn't really listening. He really wasn't using the type of dressings we had recommended. So at day 60, the wound was pretty significantly larger, more inflamed. It had a lot more bioburden, a lot more bacteria in it. We had a care conference with the patient and set some realistic goals for him. We got him referred to a diabetic educator and weight loss management. We started him on the silver oxysalts to help with debridement of that slough and bring down the bioburden. Once the wound bed was cleaned, we switched him over to the ORC collagen, which was inserted into wound 3 times a week. We also covered that with the specialty absorbent dressing. And he was able to get his A1C down to 5.1 after 6 months. And you could see at the 3 month, 4 months, 6 months, how much better or more improved the wound bed was. And the wound did go on to healing. I'm going to talk to you a little bit about offloading. So when we talk about diabetic foot ulcers, we cannot not talk about offloading. So the gold standard for offloading is the total contact casting system. However, they're often cumbersome for our patients. They're time consuming to apply. So a lot of times people will just use a crow walker or a walking boot off of the shelf. You can also get a custom orthotic or custom shoe for the patients, depending on the anatomy, duration of use, and the complexity of the modification needs. I wanted to add a couple things about CMS's coverage bills, just because a lot of times we don't think about this. So CMS may cover the therapeutic shoe and inserts for persons with diabetes. The benefit is limited to up to 1 pair of shoes and 3 pairs of inserts or shoe modifications per year. This is important because a lot of times our patients don't even know that they have this service or that they could qualify for these things. However, they do require a lot of documentation. So you have to make sure you're documenting the patient has diabetes, he's in a program for his diabetes, that he's had partial or complete amputation. If there's ever been an ulceration, you have to be specific about the assessment for poor circulation. Other things that are important to note that are required is that you send in copies of the notes, and also important that the orthotist sends a thing to the patient's actual PCP. Then they must have a face-to-face or clarifying statement saying that the PCP is managing their diabetes. That's where it gets a little bit tricky. So in conclusion, diabetes can impact wound healing. Patients with diabetes can be unique in their foot structure. Diabetic patients are at high risk for the development of life and limb-threatening amputations. Diabetic patients can have micro and macrovascular compromise. Then advanced topical dressings along with offloading can help to heal diabetic foot ulcers. Thank you. And now I will turn it over to Daphne Hodges to talk to you about pressure injuries.
Thank you, Emily. My name is Daphne Hodges, and I am going to be talking to you today about pressure injuries in the post-acute care setting. Pressure injuries used to be and are still occasionally referred to as decubitus ulcers, bed sores, or pressure ulcers. In 2016, the terminology changed to pressure injury, and the National Pressure Injury Advisory Panel revised the staging system. You can review the position statements and complete definition of each pressure injury stage on the NPIAP website. Pressure injuries are defined as localized damage to the skin and underlying soft tissue, usually over a bony prominence or related to a medical or other device. I really like the depiction of what happens here to the body's tissue in both of these figures. I think the picture on the left are what most people are familiar with. However, the one on the right is less recognized. I see this in practice when I roll a patient over to assess their skin, and they've been lying on a urinary drainage tube, a roll of tape, or a call light. Here's my favorite, and not at all depicted in the picture above, but soon after I started working at my hospital, I noticed that our critical care setting had an endemic herpes outbreak on the lips of all of our intubated patients. Those pressure injuries from the ET tubes were mistaken for a viral infection. I'm proud to say that I managed to cure all of our herpes. But the moral of that story is that we need to identify the etiology of the wounds, and that'll guide the diagnosis. Pressure injuries occur as a result of intense and/or prolonged pressure, or that in combination with shear, as we often see in those individuals who are sliding down in bed in their chairs as the sacrum and coccyx or heels move in an opposing direction of the soft tissue. This may be seen over bony prominences, but the sacrum, coccyx, and heels are most common. Tissue tolerance is affected by microclimate, nutrition, perfusion, and the individual's comorbidities. Remember that only wounds with known etiology of pressure should be called pressure injuries and be staged as a pressure injury. Over the years, I've seen clinicians assign a stage to any observable wound. I've seen venous leg ulcers labeled as unstageable pressure injuries or diabetic neuropathic foot ulcers called a stage 4 pressure injury. Examples of wounds that I had seen commonly confused as pressure injuries are bruises, incontinence-associated dermatitis, intertrigo, skin tears, fracture and edema blisters, herpes, COVID-19 lesions, and peripheral arterial disease. These are by no means an exhaustive list, but you can see how this could be misconstrued as a pressure injury if there isn't a deeper understanding of the patient's history or comorbidities. So now that we've covered what pressure injuries are and what they may not be, let's get to what we're all here for, and that is looking at the best practices for pressure injury prevention. A systematic approach to pressure injury prevention through the use of a bundle has been shown to lead to better outcomes, as described in the document published by the Agency for Healthcare Research and Quality, titled Preventing Pressure Injuries in Hospitals, a Toolkit for Improving Quality. The recommended bundle includes performing a comprehensive skin assessment, utilizing a standardized pressure injury risk assessment, implementing interventions, and care planning to address pressure injury risk factors. The NPIAP recommends skin inspection as soon as possible upon admission, but within 8 hours and then at minimum daily. However, you should check your organization's policies and procedures to ensure that the skin assessment is timely in your setting. In my facilities, the expectation for our staff is to perform a head-to-toe skin assessment within 4 hours of admission. This not only helps us provide the opportunity for timely treatment, but to also provide the interventions and timestamp what is present on admission. There are 3 common risk assessment tools utilized globally today: the Norton, the Waterlow, and the Braden. The Braden scale is the most commonly used in the United States. The NPIAP recommends that there be a routine schedule in which skin risk assessment is performed. In a long-term care setting, the risk assessment should be conducted weekly for 4 weeks, and then quarterly, and then as needed when there's a change in condition. In the acute care setting, the NPIAP recommends that skin risk assessment be performed every shift and as needed, and then again change in condition. But like the skin assessment, you should always review your organizational policy to understand what is expected by staff as far as the frequency of skin risk assessment. So the skin risk assessment and the skin assessment have been completed. Then what? We need to individualize prevention measures and care planning. A retrospective case control study revealed that there was a poor correlation between the total Braden score and the implementation of pressure injury prevention measures. The authors suggested that subscores be viewed as independent risk assessments and that interventions should be individualized to the patient based on those subscores rather than the total Braden score. So when you're looking at the completed Braden scale, while the total gives you some idea as to whether or not your patient is at risk, you should really be paying attention to those subscores of 1 or 2 and tailor those interventions accordingly. I'm sure the vast majority of you have seen this Braden scale that you see here and understand the purpose of this chart. As a specialist in wound care, I know that I often assume that all nurses know what the Braden scale is for and that they actually know that what these categories are listed in the first column. I've also made the assumption that they understand the importance of each of the following columns and how it drives the care that they provide. But when I started working for my organization, I came to the realization that the Braden scale was literally a bunch of checkboxes for nurses to complete as part of their daily routine. However, they made no correlation to the pressure injury prevention measures that they have come to learn as standards of care. I had to figure out a way for them to understand what and why they were scoring their patients and how that intervention was related to those patients. And I wanted their pressure injury prevention practices to be more meaningful. So let me take you through this journey of mine with my staff, as mine have come to learn that I have a color-coded version of the Braden scale. Now, before I jump to the color-coded version, let's go back to the whole concept of bundling. Here you see the skin bundle that has been used at my facility for the past 8 years. The original skin bundle was born in 2004 at Ascension Health at St. Vincent Medical Center in Florida as an initiative to eliminate facility-acquired pressure injuries. SKIN is an acronym for support surface, keep moving, incontinence or moisture management, and nutrition and fluids. The interventions listed in the third column are those that are commonly used and are practically a standard within our facility. So it wasn't a complete surprise to them that when I introduced this bundle that, it was pretty familiar. The majority of patients actually had at least one intervention in each of these boxes in use, unless it was absolutely not necessary. This chart and bundle help them frame their tasks in a more meaningful format. After I tailored the skin bundle to fit our setting, I realized that each piece of that acronym aligned with the subscales of the Braden scale. And so I color-coded both the Braden scale chart and the skin bundle tool, and this light bulb went off in my head. And perhaps some of you already saw this on your own, or perhaps it exists out there somewhere in the wound care world, but I hadn't. And so I was completely excited to share this with my nurses. When I showed them the parallels, they were just as amazed that all along they were doing the right thing by addressing all the contributing factors as listed in the Braden scale. Nurses were already implementing prevention measures where they felt it was necessary based on patient presentation. But to their amazement, they addressed the Braden scale and the patient subscore with little to no effort. And in many ways, this validated their thought process and ultimately gave them a much smaller to-do list. In other words, they needed to go now to the subscores that were 1 or 2 on the Braden scale and drop down to the skin bundle assessment tool to ensure that one or more of these interventions were checked off under the corresponding color, and double check that those were a part of the patient's active interventions and on their care plan. So let's take a look at how that actually works. So for a patient who has a Braden scale tallied for a total of 17, the patient may not be considered at risk. However, based on the current recommendations, we would look at the subscores of 1 or 2. In this case, that's moisture, activity, and friction and shear. If you move to the corresponding color on the colored skin bundle tool on the right, you'll see that the S, K, and I should be addressed. That is, interventions addressing support surface, mobility, and incontinence and moisture management should be implemented and individualized to the patient's exact issues. On the next slide, we'll take a look at some of the common interventions related to each aspect of the skin bundle. Remember that S stands for support surface. Implement an appropriate support surface for both the lying and sitting surface. You may choose a static, low air loss, alternating pressure and or immersion therapy, depending on the determined risk factor and or actual skin condition. Consider using a transfer sheet to help reduce the amount of friction between the bed's surface and patient. The K stands for keep moving. Ambulation, turning, and repositioning all keep patients moving. So you might consider a turning schedule similar to the one you see here on the slide. The standard of care used to be turning every 2 hours, however, while the patient is in bed and repositioning hourly when in a chair. However, the NPIAP is supporting a more individualized turning schedule now, depending on the patient's activity, level of mobility, and ability to independently reposition. The I stands for continence or moisture management. And for those who are incontinent, consider a toileting schedule. For those who are exposed to high levels of moisture related to incontinence, ensure that they have good skincare and include prompt cleanup with a pH balanced cleanser and application of barrier creams. Seek out absorbent and breathable underpads and undergarments. A low air loss mattress will also help with managing the microclimate beneath the patient, helping to keep the skin dry. The N stands for nutrition and fluids, and if your patient is not receiving adequate amounts of nutrition or fluids, they may require supplements or the assistance of a dietitian to make recommendations for changes to the plan of care to ensure that their intake is meeting their daily needs. Remember that the presence of a wound and other health conditions will increase nutritional demands. While the skin bundle places very important interventions in a succinct format, it was developed back in 2004, and the research continues in the area of pressure injury prevention. There are more interventions that we should consider. The Prevention and Treatment of Pressure Injury Guidelines of 2019 recognizes that there's a growing body of evidence supporting the use of prophylactic dressings, specifically soft silicone multi-layer foams on vulnerable parts of the body for those patients at risk. Multi-layer dressings may reduce friction, shear, and pressure, and reduce the likelihood of altering skin moisture to a point where the skin may be weakened. Select a dressing large enough to cover a wider area from the center of the bony prominence where there tends to be higher levels of pressure. This will actually help to disperse and transmit shearing forces away from this area. Prophylactic dressings do not replace other pressure injury prevention measures. It's imperative that you build into place a process of routine monitoring and assessment of the dressing and the skin beneath it. The Prevention and Treatment of Pressure Injury Guidelines recommends that these dressings be considered for use to protect skin and as an adjunctive therapy to other pressure injury prevention measures. While we're very familiar with the pressure injuries found on the sacrum and heels that account for about half of all pressure injuries, we can't forget about medical device-related pressure injuries. Kaesner and her colleagues in 2018 found that 75% of all medical device-related pressure injuries are facility-acquired and that they are more likely to form 3 days faster than non-device-related pressure injuries. This means that medical devices should be one of the areas focused high on our priority list when it comes to pressure injury prevention. Consider using a dressing under medical devices to pad and cushion the space between the medical device and the tissue beneath it. The consensus document on the role of dressings in pressure injury prevention contains this algorithm that might help to guide you and your facility on the use of prophylactic dressings. Aside from the well-known interventions mentioned on the previous slides, we can't forget about some of the very important members of our healthcare team. If you don't already have an active early mobility team, consider recruiting your rehab services department. Physical therapists and occupational therapists can help improve mobility. Their interventions will not only help reduce pressure under bony prominences, but they can help to strengthen and prevent muscle wasting, thereby improving rehabilitation potential and prevent falls where possible. Our speech therapists play a pivotal role in evaluating and treating patients to prevent aspiration. And as we know, aspiration pneumonia can be debilitating and place one at additional risk for immobility. Recreational therapy is important in a post-acute care setting in helping to get people out of bed and offer social outlet, improving mental health, which is very important in preventing depression, which often manifests physically by leaving one to refuse and participate in any activities out of bed. Your dietitians and food services staff are key in helping to ensure that food choices are available to optimize caloric, protein, and fluid intake. And don't forget about your team of certified nursing assistants who are your eyes and your ears. They can help with early detection of impending pressure injury development and can also ensure that prevention measures are carried out as part of their daily workflow. Prevention and Treatment of Pressure Injury Guidelines of 2019 recommend assessing the knowledge of healthcare professionals within the organization and implementing educational programs accordingly to cover prevention and treatment of pressure injuries. As covered above, it's important that all individuals of the healthcare team participate in prevention injury education and as a collective effort to prevent and manage pressure injuries. Patients and family members should also receive instruction and education about pressure injury prevention and management so they can participate and support your efforts while in your care. Topical treatments of pressure injuries shouldn't really be different than treatments of any other wounds, except for the fact that we must additionally acknowledge and address contributing factors. Negative pressure wound therapy may be a treatment modality less traveled in the post-acute care setting, and it is often dependent on the level of expertise and prior experience of the clinicians managing the wounds in that facility. But consider negative pressure for treatment of those stage 3 and 4 pressure injuries. The results might actually surprise you. I'd be remiss if I didn't speak to the existing pressure injuries that I see admitted to my hospital from post-acute care facilities in chronic conditions that might have been treated for months with continued deterioration. This case was a stage 4 pressure injury to the sacrum with evidence of existing unrelieved pressure with necrotic tissue hovering over the wound bed. By debriding the necrotic tissue, applying negative pressure wound therapy, and placing the patient on an appropriate surface, in this case, we placed the patient on a low air loss mattress with immersion therapy, you can see that the purple area had resolved and the wound was already beginning to improve. This patient came into the hospital from a skilled nursing facility with 2 stage 4 pressure injuries that had been treated with negative pressure wound therapy for a few months without any improvement. By the time I was consulted, I discovered that this non-healing pressure injury was actually one large stage 4 pressure injury hiding underneath a bridge of skin. I requested a surgical consult for debridement of that bridge, and by debriding that bridge, we were able to have better access to that wound for a more effective placement of the negative pressure wound therapy dressing. This patient came into my facility wearing adult incontinence briefs and had high levels of wound exudate. You can tell in the photo on the left that there were some moisture issues surrounding the wound, and there was a significant amount of necrotic tissue within the wound. I placed this patient onto a low air loss mattress, requested debridement of the wound, and applied negative pressure wound therapy to this patient. And within a week, you can see the improvement in the surrounding tissue and the quality of granulation tissue. A meta-analysis of 16 randomized controlled trials, including 629 patients, compared standard wound care, which in this case was moist saline dressings 3 to 4 times a day, to negative pressure wound therapy in stage 3 and 4 pressure injuries. As you can see, there are many benefits to including negative pressure wound therapy as a treatment modality for full thickness pressure injuries. But don't forget that you must control the environment and conditions that place the individual in the position of developing the pressure injuries. Ensure that the skin bundle is in place because local wound care alone won't be able to heal the pressure injuries. In summary, assess the healthcare team's knowledge and educate them about skin assessment, skin risk assessment, and pressure injury prevention measures. Bundle up. Remember that bundling helps to improve your chances of successful outcome. Individualize interventions and care plans. Optimize your treatment of pressure injuries by ensuring you address the contributing factors of pressure injury development in each individual case. Educate yourself on the products and tools available to you. Contact your local reps of the companies that manufacture support surfaces, mobility devices, advanced wound care, and skin care products, and other commodities such as underpads and incontinence briefs. There are lots of products on the market, and while there are lots of similarities, there are also differences between them. While they may look the same, they're actually not all created equal. Prevention and treatment may be the same, but remember that in order for treatment to be effective, it should always address the conditions that contributed to the wound in the first place. Manage moisture if the individual is diaphoretic. If the patient is incontinent or has a wound with large amounts of exudate, make sure those are corrected as well or managed. Use moisture wicking products, low air loss or toileting schedule. Use a specialty support surface or offloading device to assist when a patient is unable to move independently or with minimal assistance. Use a glider sheet to help reduce friction forces and limit layers of linen beneath the patient. Use a trapeze so that the patient can self-reposition or assist with that repositioning. Consider the patient's girth not just for weight, for the use of a bariatric bed. They may actually require more space on either side of them to allow for turning. Expand the use of your rehabilitation services to prevent deconditioning and strengthen your patient so they can assist with pressure injury prevention and treatment. Thank you for joining us today, and that concludes our program.